Hello and welcome to the EGVRS Around the Retina World in 30 Days. My name is Dina Bador and it is my pleasure to have Dr. Susana Teixeira from Lisbon, Portugal with me today. Dr. Teixeira is a vitreoretinal consultant with special interest and over 25 years of experience in ROP. She practices in Hospital Fernando Francesca, which is a tertiary referral center for ROP. She also shares her time with Hospital Duluth, where she does medical and surgical retina practice. Welcome, Dr. Teixeira, to our program.
Thank you, Dr. Dina, for the nice presentation, and thank you for inviting me for this Retina Around the World from the GVRS. So I'm going to present my country where I do work. So I work in Lisbon, and my country is here in the nose of the Europe. You can see Egypt is more like here, and we are here. And in Lisbon, it's a very wonderful city because we have a river. This is Lisbon, our famous bridge, 25 April Bridge. Here is Lisbon. So I see Lisbon in this picture from the south of Lisbon. We have this pastéis de Belém that Tina very interestingly wanted to know what it is. It's made of eggs and cream and it's a wonderful taste and very, very sweet. And in the south of Lisbon, we have wonderful beaches. Here is Costa da Caparica. It's a beach near 10 kilometers from Lisbon. And in Algarve, it's in the south of Portugal. And I do live by this stadium, Benfica Stadium, is a football stadium, very famous in Portugal. Of course, Portugal is very different from the north to the south. We have completely different landscapes away from beaches with rivers, with olives, and in the north of Portugal, my parents are from the north of Portugal, from Douro, where we can make Oporto wine. In the north of Portugal, we can have these landscapes with grapes, with figs, with almonds. We have granito, it's a kind of stone, very, very, very different from the north stone, and olives. So we also have islands near Portugal. So we have Madeira and Azores, and this is a landscape from Madeira with wonderful beaches. And this is Porto Santo is another little island near Madeira. So from the north to the south, we can have completely different landscapes and different foods. And for instance, I told Dr. Dina, we have cheese, completely different cheese from the north of Portugal, center of Portugal, south of Portugal. So you can taste very different flavors in a very little country.
So the south is where the sea is, and then the west is where the Atlantic Ocean is, right?
Yes, right. And in the south, we also have Atlantic in the south, and we don't have a coast really to the Mediterranean. But the Phoenicians came from the Mediterranean and came to make commercial merchandise in Portugal. So that's why we have this Mediterranean identity, although we don't have really a Mediterranean, just Spain does have it.
All right.
Any question?
So, this looks beautiful already.
So, well, I share you just a little bit of my story and why ROP. And I was a general ophthalmologist until I came to work in Hospital Professor Dr. Fernando Fonseca. I never saw a retina of a baby, but I was given the work to work with babies. And I said, okay, I never saw a baby, but I do retina of babies, if you allow me to do retina also of adults. So in my hospital, I began to work with adults and with babies. I was very afraid the first day I looked at the baby, but as soon as I saw the retina of a preborn baby, I was passion. It was like an epiphany. And I said, oh my God. So it was really an epiphany when I saw it. And suddenly I was just doing retina of adults in other hospitals, and suddenly my life was popcorn with babies and indirect ophthalmoscope and babies crying and families speaking with me and doing treatment of laser. I was already doing laser in adults, and then it was just a step to do also the ablation of retina, peripheral retina of the babies with laser. So my life was popcorning with babies all the time. And in addition to retina of adults, I love to do this. But I suffered a lot because even with all the treatments that we did to the baby, all the ablations that we did to the baby, I had bad results. I keep having bad results. So when I look at zone 1 ROP, I already knew that half of the eyes would get blind. So there was a day after ETROP that I look at the baby and I saw again an aggressive disease. And I saw, okay, I know I'm going to do laser and the baby is going to get blind anyhow. The right eye of the baby was okay with laser, but the left eye, it was terrible. So we decided to do an anti-VEGF in the baby, exactly as we did already before the vitrectomies of the diabetics in the adults. And it was amazing. I was terribly afraid in the next day because I was afraid to have an endophthalmitis, to touch the lens, to have a cataract. So it was, but when I looked the day after, I said, okay, so that's the way. That's the way. And
Yeah.
I published it. The first time I presented it was, I was invited by Philip Rosenfeld to present it in the Angiogenesis in Bascom Palmer. And he made me publish the results. And suddenly I was inside the world of ROP with the World ROP meetings. We have already 3 World ROP meetings. The first in Lithuania, it was wonderful. The second in China, then in India. Oh yeah, so the second was in India, and the third one the fourth one in Cancun. And it was an obligation of mine to show everybody the results we were having in ROP. And I had mentors, I had people, although all the world was a little bit against this off-label treatment, I had mentors. So I had, I can see here, Cesare, I don't see here Cesare. So there was an organization, Ravenna, with my great mentor, Cesare, as you can see here, that organized meetings with young people with young ideas. And he was one of the guys that helped me and projected me, showing the use of the anti-VEGF in ROP. And almost all the world at the same time was using anti-VEGF. And he used to organize this Mediterratina meeting. One of the meetings that nobody would ever forget was the cruise that we had in the Nile, as you can see here. And the cruise and the philosophy of Mediterratina is let's come with the family, and we have time for family, and we have time for science. So time for family and time for science. And this was incredible, this cruise that if you speak with people that were in this meeting, it
Do you
was
remember
incredible.
what year it was?
It was in 2009, I don't know.
Oh.
For sure, 7, 8 or 9. It was something like this. It was
Right.
very long time ago. And then EVRS is also an organization that welcome people, young people with different ideas, and is a place to debate, free debate, from the north to the south, from the Europe to the Africa so all the countries go there and freely debate ideas. So that's the own way of EVRS. So EVRS also was a platform to show everybody how it's important to take care, to screen and to treat ROP. And of course, EGVRS, by the hand of Professor Mortada, he invited me for two meetings in EVRS, and again, I felt very much at home when I was in Egypt, because the scientific level of retina, that's what I know best in Egypt, it's amazing, really. It's not just because you invited me, and the quality and the platforms that people show their in the platform, they show their surgeries and why they do it, and the mastery as they do it is it's very good to me. So I've got friends in Egypt, and when I have got a problem with a patient, I ask my friends from Egypt, because they have so much interesting, good, and based on experience, opinions that I trust them. So the other part of my life that I love to do is missions. Of course, I can, for personal not problems, but it's states, I cannot do all the missions I would like to do, because well, I must work.
Yeah.
But I love to go in mission and see and try to help other people, of course, and understand how we could do it better there. So I've got, if you want, then in other interview, know the aim of the missions. It's something that fulfilled me very much. My cats, I'm a cat person. I love dogs, but I'm a cat person.
Mhm.
And my child. So I've got Marta. She's now 19 years old. William, it's an engineer, so it's a mechanical engineer. And John deals with gestion and financials. So those are the other pole of my life. And I think we must always have a lot of poles. And I don't work alone. So in all the hospitals where I work with a team. So it's very difficult to me to work alone. So I love to work with a team, and the best work is always the work that comes out from a team. So now I am the face in this interview, but really my words come from all the support I have and I give. So it's a teamwork. And for me, it's the most important thing is the teamwork. So
Wow. This is all amazing. Tell me, do you have children that you treated while they were young come into clinic and they're professionals right now?
I couldn't understand it.
Do you have babies, RP babies who come into clinic and now they're in school and
In school.
the
So my first treatment now, the first treatment with laser, he has 22 years old, and he presented me his fiance. So
oh,
he's going to
sweet.
get married. So we become, to make ROP is just not a technician act. It's a very exquisite, unique technician act, but you have to make connection and trust and
Mhm.
with all the family. So a baby that is premature, it's a very heavy weight in your shoulders, because it was very desired. It was a problem, and you must explain everything you are going to do. And before they come to the ROP problem, they had the neck problem, the interventricular,
Mhm.
the
Mhm.
sepsis, and all that. And the baby is so well, and then suddenly it can get blind, and you
Mhm.
have the mother and the father, and you must explain everything. So they stay
Absolutely. Yeah.
your family for life. So
Mhm.
the first one, baby, I made laser, is now going to marry. So he wanted to an appointment with me with her fiance just to show me her, not for an appointment for ophthalmology. And the first baby I treat with anti-VEGF, I follow up all the families. So I'm a family ophthalmologist, as I used to say. So it's
Nice.
very fulfilling me, and I think ROP
Mhm.
fulfills you, because this link with the family is very strong. And that means that I'm always very worried also, because a strong responsibility for that baby. But we also deal with, I mean, with the NICU, with pediatricians, with nurses of those babies. We deal with everybody, and everybody is very important for the work that you do will be a successful work. So if I don't take care of my doctors, of my nurses, if I don't ask them and show them what they must do, and I don't involve them in the work, the work will not be effective.
Absolutely.
So to make ROP and to be with those different spheres of life, I mean, the NICU, the parents, sometimes the ethics. So I must have a lot of discussions of ethics with the hospital. So it's a very involving work, and not all the personalities do work well with this. I mean, we have a lot of people that come to us to learn how to make the screening and treatment of ROP, but when they see this complexity, not all of them like it, you know.
I understand. So with this heartwarming note, we go to a break and we will be right back.
Okay.
All right, and we're back with Dr. Teixeira, who is going to talk to us right now about the fluorescein angiogram in ROP, a new dimension. Go ahead, Dr. Teixeira.
So let me share the screen. Well, so I'm going to share with you my experience with the use of fluorescein angiography in retinopathy of prematurity. We know that it's the indirect ophthalmoscopy, the hallmark, and how we really make the diagnosis and the decisions in retinopathy of prematurity. But we can use also RedCam, Optos, and iPhone. And I began to use the angiography mode in RedCam, and it became very interesting, all the images. It was very compelling to me, all the images I had. So I could look inside the eye, and I really know, imagine what's happening inside the eye. But when I project and have the angiographic image of this eye, I've got much more information about what is going on inside the eye. So you can see here, of course, I can see here that we have a shunt. I can see here that we have some kind of disease, but only when I put the angiography inside the eye, I can understand really that we have a shunt here and we have some kind of retinopathy here. So angiography in ROP was a very informative tool to me in the diagnosis. So you can see perfectly that you have a stage 3 here, but really that's how much activity you have in this stage 3. And you have a stage 3 here, but you also have stage 3 along the vascularized retina. So it's a much more active disease than the other one. Let me go. Here the same, you can find all the facts that are going on inside the eye, as you can see here, always stage 3 with popcorns. So you can see it, but here you can have much more information about how it works inside the eye. And even you can look to the front of to the anterior segment and see if there is some leakage or not in the anterior segment. So it's not a plus disease, but can tell you about the activity inside the eye. So it's a wonderful tool. And you can see all the capillary, how is the capillary bed inside the eye, if there is some kind of ischemia behind the front of the retinopathy of prematurity. Even when you already did all the treatment, you can see if there is any kind of activity in the transition or some kind of ROP activity after the treatment. As you can see here, we have fibrosis, and you can see a little bit of staining of this fibrosis. Of course, we must always, even if we did the treatment, we must always looking if the disease is going on or not. It gives us some information very interesting about the peripheral features after intravitreal anti-VEGF. It was one poster of mine in the China World ROP meeting. And we can find very interesting things in the ROP babies with a very posterior ROP, and in the babies choroid. What can I say? Everybody speaks about the vascular tortuosity and all the problems of the vessels of the retina. But can I see? But the choroid also suffers with prematurity and with retinopathy. And we can see that in this pachychoroidal filling in some babies that have the most bad ROP. And you can see it in OCT that have thin choroids, those babies. And we can see what we are used to see in the retina. So you can have vascular shunts, the tortuosity for life of these babies, anomalous branching of the tertiary vessels, but you can see it better again with the angiography. You can see those vascular shunts, the abnormal vascularity of the tertiary vessels. You can see vascular shunts, and those vascular shunts, interestingly, are not just artery vein, but they are vein. So if you can go home and study. When you see the baby in direct ophthalmoscopy, it's indirect ophthalmoscopy at the time, but you can bring those images home and study those images. That's the other thing that we can also do. And we have very interesting things. This was an anti-VEGF baby injected with anti-VEGF because of zone 1 ROP. And we have this, I never saw this before, a tangled vessels. So you have all the vessels tangled and not growing to the vitreous, but tangled, but without activity. So you don't have stage 3 disease. It's a tangled vessels that I follow up, and it worked having really then a stage 3, but at the time it was just a different conformation of the vessels. So we have a lot of information with this exam with angiography of fluorescein, and we can go on and see how much the vessels grow after the injection. So this is the first place where there was the disease, and then the vessels grow, and you can measure how much it grew for how long it for the time it was injected. But not only the eyes of the injected eyes have this different configuration, but also the non-injected eyes that had a spontaneous regression of the disease also have different configurations that we studied. So we never know, I think we don't completely know if those different configurations are because of the anti-VEGF effect or because of the retinopathy in such a tiny baby. So there is a lot of information that we have with this angiography, but what most worry us are not those different configurations, are the persistent avascular retina that can be a place for recurrent disease. Well, it's a long discussion, that persistent avascular retina. We don't know really if all persistent avascular retinas will have recrudescence of the disease. And I follow persistent avascular retinas for a long time. So what I usually tend to do is to see if I can trust in that persistent avascular retina. What I mean, if how is the junction between the avascular to the avascular area. So when I've got a baby with persistent avascular retina, I always do angiography. If the vascular junction is calm, I mean, there is no activity of the disease, I just follow the baby. So this is a persistent avascular retina that doesn't worry me. As you can see here, I have years of persistent avascular retina with no activity, but suddenly we can have some kind of activity. And this is the persistent avascular retina that we must follow carefully. And sometimes we must make laser of those areas. So we still need to know more about ROP in order to really know what to do about those persistent avascular areas. Because even when I do laser to those persistent avascular areas, I still have this fibrosis and this kind of activity that we also see in adults. We make PAM photocoagulation and you have the retina with the fibrosis that have this stain with a fluorescein. But even with those lasers, I don't have a complete calm eye linked with the activity of retinopathy of prematurity. So we still need a lot of things to understand about those persistent avascular areas. And specifically, I'm following this young boy that is now 10 years of age as a huge persistent avascular area, but no relapse of the disease, although it has staining of the disease. So I think there is still a lot of things that we need to know. And the much I know, the much I think I don't know a lot of things. So I understand the huge things I don't understand. Angiography is, like we said, and we saw, a guide in the diagnosis and the treatment. So it can help us to understand if we have a recurrence on those persistent avascular areas, if we have a failure, or if we are really in front of an ROP or a differential diagnosis of ROP. So angiography is not completely needed to know if we have a recurrence or not. Here is a baby that I injected with anti-VEGF, but he recurred after 2 months. And we can see that we have a plus disease. We have a recurrence in the interface to the vascular retina. I did laser, so we had no doubt. But if we use angiography, you can see that in this case, we have a recurrence not only in the interface, but also in the first site of ROP. And you can see it very well with angiography. So you see we have here, begin to have here recurrence, but also have activity in the first place of the ROP. So it can show us a world of things doing this angiography, and I'm very grateful I have got this tool. Of course, it's not completely, we can do this without angiography, but with angiography, we learn much more and it's more accurate, the diagnosis we do. And sometimes the work, the treatment doesn't work as it should work because we are in face of an atypical ROP and a mix between fever and ROP, so we call it ROPER. And perhaps we have not a preterm fever and not really an ROP. Sometimes we have oxygen-induced ROP. That's a pattern very typical. I think this baby that came to me like an ROP really was an oxygen-induced ROP because we have just a few vessels around the main vascular arcades, so very similar, very typical, and behave very typical, like an oxygen-induced ROP. Although 1 year later, it came with a direct retina to the optic disc, so very similar to a fever. So we can have different phenotypes with different presentations, and I think that angiography helped us in this case. This baby came to me with a terrible stage 3 ROP to treat, and then I suddenly made an angiography and saw this, and this is veils in the vitreous. In the other eyes, you had activity in the optic disc and veils in the vitreous. So this is a preterm fever. I did laser, not an anti-VEGF to this case, because the fever is more safe, and is reactivations are more controlled if we do laser to the periphery. There is a very interesting paper from Ana Maria Castellanos that try to link all the presentations in ophthalmoscopy, in angiography, and try to make an algorithm to try to treat the best possible the baby with ROP. But we still need not a consensus, because it's very difficult to have a consensus, because ROP has different phenotypes around the world. I mean, for instance, in Egypt, perhaps you have ROP in very much older babies, like in Mexico, and in Europe, here in Portugal, we have ROP in very little babies that behave differently from Sweden. So I think it's completely impossible to have a consensus, but we must meet different doctors from different parts of the world and try to have an algorithm to treat the babies. And finally, for the future, as angiography of fluorescein in RETCAM, in this case, is a very reproducible image. We can make the same image with the same characteristics in Portugal, in Egypt, in Mexico. I think it will be a very good, something that intelligence, artificial intelligence, will bring, will pick some, intelligence to make a deep learning and to make artificial intelligence with this image, in these fluorescein images. So I hope that in the future we can have algorithms in artificial intelligence that, as we are delivering now, as we are trying now with very effectively. So deep learning algorithms, they are picking very much information from angiography in retinopathy of prematurity. But we must always remember that retinopathy of prematurity is more than treat an eye. It's treating a baby, a family, and I hope that artificial intelligence understands that must be a help to us and not substitute us, be something instead of us. So that was my message. Oh. Do you want to make any question? Do you want to?
Thank you very much for the wonderful pictures. Yes, as I was looking at your pictures, I have a question. So who do you recommend can go into ROP for your younger generation? Do you train people fresh out of residency, or do you prefer somebody with more skills in retina and geography?
Well, thank you for the question, Dina. Well, I think that if you are going to do retinopathy of prematurity, you must be somehow motivated to do retinopathy of prematurity. So you must have doubts. You must understand why you are going to do such a difficult thing. So I like to, and I think it's the most preferable, is someone that already understands what's going on and what does he or she need to know to fulfill the need of make the screening and treatment. So I think it's better to have someone that is already a specialist in ophthalmology and that knows really what has to what we can give him or her. So it's better that it is, I think it's preferable that it's already an ophthalmologist that masters indirect ophthalmoscopy. It's something that they really don't like to do. But when you know why you have to do it, for sure, you try to do it the best you can. You understand? So I
Yeah.
think it's preferable to have a specialist that already masters retina.
I think what you're saying is that somebody who is good with babies and can master retina and can do great. I think women work great for ROP.
Well, well, uh, uh, really, I shouldn't say this, but really, I think that women master it very well. Men can be very technical, and I don't doubt it. But you have to have a special empathy with everything, with the suffering of the parents and the suffering of the baby, because the baby suffers with this. And to have this dance and this balance with the team and all this. And really, I was trying to look back and see if there was one man. There are two men. Two men, what I used to say, two men of my life, that is one of my colleagues, but it's my age, so he didn't learn from me. But he's a man, and he does a wonderful work in Lisbon, in Maternidade Alfredo da Costa, in Estefânia, and he's a man. But he's a man with a mission, you know, Dina. He's a
Yeah,
man
I
that
understand.
even in the holidays, if he has to go in that day, he tries to do everything to go and see the baby in that needed day. And another one is in Algarve. He does the screening of retinopathy of prematurity. And it's the only thing he does with retina, you know, is from the anterior segment and does most cataracts and glaucoma and all that. But again, the same, a man with a mission. He knows
Yeah.
how important it is to make the screening of the babies. That is, he goes like a mission to make the screening of the babies.
So
So
we
I
really
think,
need both.
yes, I think both people, both sex has the same capabilities. I think it's most if they develop the mission to do this or not. And this can be perhaps more easily in a woman, because really the young generation is more women that come to us. But I think anyone can do it and master it.
Yeah. Thank you very much, Dr. Tashir, for your time and for the lovely images and for telling us more about ROP. Also, thank you for your great work, and I hope to see you in Egypt soon.
Thank you, Dina, for the opportunity to present all these things about ROP. And I miss my trips. I miss my being with people, not just in Zoom, but
Yeah.
really, it's different. It's
Yes,
different. And
absolutely.
namely, being in Egypt, you know, I love Egypt.
And we look forward to welcoming you. Thank you all for being with us, and see you tomorrow in another episode. Bye.